it's one of the things we've done over the years, we've chopped our health systems down to the bare minimum. They have very little capacity to expand and react to an emergency. They've become quite static and rigid, not elastic and expandable. And we need a health system that can adapt and react and then use new technologies quickly. And all of those things need to come together. So it's not just about the tests. And sometimes we get caught up on the test. It's how we use the test is the key thing.
I think this is a good opportunity also to mention how we've leveraged existing systems for COVID. So in December, we didn't know, in January, in February, in March, and April, what the whole world did is they harnessed and leveraged the global influenza network and the national influenza centers that exist in so many countries across the world. This is the global influenza network surveillance and response network, GISRIS, has been in operation for 70 years. And that is a system that has trained technicians, it has equipment, it has this whole process of electricity and reporting mechanisms and individuals who could quickly utilize that experience that they have for influenza, for COVID, for SARS-CoV-2. And that made us operate even quicker. And so how can we use this pandemic to actually further these systems that are in place so that for the next time we can be even faster? And so we still need, and I also am going to use this opportunity to say we still need to be testing for flu. So most of the flu labs were quickly adapted for COVID and stopped testing for flu. And now we're finding the right balance between the two because these are viruses that circulate. Flu circulates the globe. And as we enter the winter, we've just hit autumn in the northern hemisphere. And as influenza starts to circulate, we need all of the labs to be able to test for influenza and for COVID, so that we make sure we know what's circulating, we know what people have, because there are different clinical pathways, and so we need to, again, it's all about the action. A test is one thing, but then what does it mean? What do we do? And there are very good systems in place. So we're really grateful for the entire global influenza network that is working so hard and has so many incredibly trained individuals all over the world.
Thank you very much, Maria. One of our viewers is saying, if PCR test is not accurate, is there any new test to check out for COVID-19? You did mention there are new rapid tests. Maybe we can also explain to viewers how many different type of tests are there and what do they measure?
Let me correct something first, though, because we see the part of the question was PCR are not accurate. PCR tests are accurate. PCR tests are very, very accurate. They are highly credible. That is what is being used globally. So please let's clarify that.
Thanks.
What we were trying to highlight were the number of ways in which they can be used and how they should be used. But please be assured, PCR tests are accurate. There are different types of tests. So the PCR tests are looking for the RNA, these pieces of the virus that you are infected with. And there's lots of PCR assays that are available. And as Mike was describing, part of the goal of the consortium of WHO was to make sure that the right tests went to the right countries to utilize the machines that were in the country. I was amazed by this because it isn't just about we have 100 million tests or 26 million tests or whatever it is. It's about getting the right test to the right technician in the right lab in that country with all the supplies that are necessary for that and the right reagents and the right. So it's an incredible match work that's great. So there's the PCR tests. These are being widely used. These are highly accurate, and we rely on these globally. And you can get a test back from PCR within hours. The difficulty in getting those tests back sometimes is where the sample is collected, if the sample itself needs to be transported by car or by drone. We've even seen in some situations to a centralized lab, have the test run and have the test back. That sometimes can take hours to days. There are these antigen-based rapid diagnostic tests, and these detect the proteins of the SARS-CoV-2 virus in an individual. These are done, as they say, rapidly, where you can get results back within minutes, within 15 minutes, 30 minutes, something like that. And essentially, you take a sample, you put it in the test tube, and then a little drop of that goes onto this strip that looks almost like a pregnancy test. And it moves up and it tells you if you're positive or not. There are a number of those that are online. Some perform better than others, but as those get rolled out, as that performance improves, this will be very, very helpful. But these antigen-based RDTs, we released guidance about the use of antigen-based RDTs last week, I believe. Feels like a long time ago, but I think it was last week when we released this. But we recommend these antigen-based RDTs to be used in 4 different situations. The first is to respond to suspect outbreaks in remote areas where you don't have PCR testing. So in a remote setting, in institutions or semi-closed communities. The second one is to support outbreak investigations, which I described earlier, where you have at least one PCR positive case. This will help you understand the extent of that outbreak. You could test your contacts, including asymptomatic close contacts, and it'll help you understand who's at risk and who is infected. The third is to monitor trends and incidents in specific higher risk populations like frontline workers, for example. And again, they will work better in settings where you have more virus circulating. And then the fourth area is in areas of community transmission. And so those types of areas will really, antigen-based RDTs will be very helpful to use and will take the pressure off the PCR systems that are in place. So these are the 2 main tests that look for active infection. Am I infected with SARS-CoV-2 virus now? There's a third type of test, which are the serologic-based tests. These will measure the levels of antibodies in an individual. And antibodies develop after 1, 2, 3 weeks after infection, sometimes longer, and will tell you if you had been infected in the past. We don't recommend those for active case finding, but those help us understand the extent of infection that had circulated in the population. And that helps us understand, how much room does this virus have to spread. You want to add?
Okay. there is a follow-up question from our Facebook viewer.
Yeah.
Why are there so many tests for COVID-19?
Why are there so many different tests, or why are there so many tests available?
Different tests.
Because they measure different things. And they're all helping us to really, again, reach this goal of suppressing transmission and saving lives. The fact that we have the market almost flooded with these tests is a positive thing. There's innovation that is happening. We talked about 2 types of tests, but there's all these other types of tests that are out there that are being explored, and it's really pushing the boundaries of what we can do. And I think that should be celebrated. There does need to be this proper evaluation so we know how well they work, and there's processes in place that do that. But I think that this is a good thing. I think this is a really good thing. And we're always looking for new technologies, and we're looking for new advances to be able to have quicker, more rapid tests close to the patient. We call these point-of-care tests. So if you're in a hospital bed or you show up at a primary care clinic somewhere and you need a test, how quickly can we get that result back to you?
But there is I think in future, it's happening already, and I think there is this emergence of we call multiplex testing, the ability to use the same platform for diagnosing multiple different infectious diseases. And I think we are reaching a point, and I think somehow on the lab side, if you remember, cast your mind back to the 50s and 60s, those of you who can remember that far back, when big companies were asked, how many computers would the world need, it was like less than 100 now. When we looked at telecommunications infrastructure around the world, and people wondered how developing countries were going to develop all of the telecommunications infrastructure, and mobile phones came along, and countries have leapfrogged the need to develop all of that heavy infrastructure by having a much lighter infrastructure that does the same job. I think we're seeing the same ultimately in laboratory science. In the old days, we saw the big public health laboratories, the National Public Health Lab, and there was a lot of investment in bricks and mortar and labs and walls and things, and it was very much it was almost like one of those magical scientists where you had to be hugely qualified, and it was it was kind of a mystical thing how lab people made diagnosis, and to be quite frank, some of my laboratory colleagues are some of the most clever, innovative, creative people I've ever met. But I think we're seeing much more so now, this with the 4th Industrial Revolution, with miniaturization, the same way as we've seen with the computers, we're seeing a revolution in how we make diagnosis. And we're seeing platforms emerge that can diagnose at the same time 90 different infections simultaneously. And I think we're going to see a brand new era. And I think maybe if the COVID pandemic has, I think, generated its own momentum to solve the COVID diagnostics problem, but I think it's also going to drive a new era of innovation in laboratory science and in diagnostic platforms. And I think we're going to see a lot more miniaturization. We're going to see a lot more multi-diagnostics. We're going to see diagnosis move closer to the patient, more into the hands of the clinician and the nurse and the doctor, the things we want to see. And I'm hopeful that that's the direction we're going. So it does seem confusing when you open up a newspaper and there's 70 different companies producing 200 different tests. It's confusing for us at times as well, I can assure you. So I can really understand where the listener is coming from. But I think Maria's right. We need the innovation now, but we also need to move to a more multi-diagnostic platform where we don't just have to keep climbing the same hill of diagnostics every time we have an epidemic.
Wouldn't it be wonderful to be able to collect a sample and put it in a machine, and that machine come out and say, there's all these different things. You've got this or that. I mean,
we don't have that
we don't have that yet, and I think that's why in the beginning, when you have an emerging pathogen like SARS-CoV-2, when you don't know in the beginning, what labs will do is they'll take a sample from a patient who's sick, and it's normally they show up in hospital, and this is the situation that happened in China. They identified patients with pneumonia of unknown etiology, and that means they didn't know what it was, because when you run it through the lab, you run it for influenza and SARS and MERS and for all of your known pathogens. And then once you exhaust that, you say, okay, what is that? And so we're getting quicker at being able to do this, and full genome sequencing is helping tremendously push that. But we're also seeing innovation-wise of looking at saliva-based testing. How can we take different types of samples? Think about kids and sampling children. And if you need to take blood versus you need to get a nasal swab versus if they could just spit into a cup. So there's lots of different practical things that can help diagnostics move faster. And so all of that innovation is happening. And so, yeah, it's pushing it. And each one of these events, because this will not be the last pandemic, and it will not be the last emerging pathogen, but each time we're in a better situation. But let's see how we use this as a way to drive this even further and faster.
There are some questions coming about de-isolation and discharging from after having COVID-19. What are the recommendation? Is it repeating tests? But I want to read this one in particular. Okay. Some countries still require 2 negative tests to de-isolate COVID-19 patients if they are baseline immunocompromised or HIV or on chemotherapy treatment. Is there any evidence to support this approach?
So that's a really excellent question, a very specific one. So WHO, what we do is we work with our lab partners, we work with clinicians, we work with epidemiologists to really understand patients, and we understand when someone is infectious. So what we understand from the data that is available, and to do this well, you need to follow the same patient over time and collect repeat samples from those individuals. You need to do that from asymptomatic cases, mild, moderate, severe cases, so we really understand, is it the same depending on your disease? What we understand for and what our discharge isolation criteria is based upon is that type of data. What WHO recommends is initially in the beginning of the pandemic, we recommended 2 negative tests at least 24 hours apart. When you have a pandemic that has at least 31 million known cases, and there may be more that are currently unrecognized, testing becomes challenging. So we were asked to look at the data and to try to come up with non-test-based discharge criteria. And when I say discharge, I don't mean discharge from hospital. I mean discharge from these isolation procedures because they're no longer infectious. So for an asymptomatic individual, so this is somebody who tested positive once for a PCR test, our recommendation is 10 days isolation, and then they can be discharged from isolation. For a symptomatic patient, what we recommend is 10 days from symptom onset, plus an additional 3 days after their symptoms get better, their symptoms resolve, meaning they don't have fever and they don't have respiratory symptoms. Now, countries can continue to use testing as part of their discharge criteria because some individuals may be test positive for longer. But what we know from PCR testing is that the PCR test itself will measure parts of the virus itself. It doesn't tell you if there's live virus that's replicating and that they're infectious. What we need for that is to do what's called virus isolation, where you take the sample and you try to grow it in a lab and see if it can grow. And that means that it's replicating and that it's infectious. So that's what the isolation criteria is on. And we know for immunocompromised individuals, they can test positive, PCR positive for long periods of time. And so some countries will still require that 2 negative tests. So we give the option. We wanted to give options to all of our member states to be able to say, if you don't use testing, this is the criteria. We have this online. We have an infographic which we could provide that makes it a little bit easier to follow. But that's where we're coming from. And we constantly look at the data, and we constantly are looking at what is new. The reason we have this for symptomatic patients, the 10 days from symptom onset plus 3 days of symptom resolution, is because we know that severe patients can shed live virus longer. And so we want to just ensure that, and those individuals are hospitalized, so they're already in isolation. So it's a long answer, but it's because it's based on a lot of different criteria.
Yeah, and I think it may be a useful idea, and thank you for the prompt on this, listener, because I do think the concept of immunocompromise is very broad.
Yeah.
We have many people living with HIV who are on therapy and they're perfectly well. They're not immunocompromised in that sense. There are many people equally with different levels of autoimmune disease who may or may not be immunocompromised, depending on what stage their disease is at, or So I do think it may be useful for us, Maria, to bring together a group and look specifically at this group in terms of that evidence you speak about, so we can give better guidance to countries, because we don't want to be in a position necessarily where people are being held in hospital or being told to self-isolate for longer than they need to. It's tough enough to live with the disease associated with immunocompromise than to be further isolated more than you need to be. So I do think it's worth us taking a look at that again, and that specific thing.
And we hope our collaborating centers and our labs that are able to carry out this type of research are doing so, because you really need good data. You don't need this type of study in 100 countries or even 10 countries. We need a well done, well characterized, well conducted study following individuals, taking repeat samples and providing that data. So we work with a group of an entire international network of laboratorians and clinicians, and so yes, this is something we will continue to look at.
I thank you very much. I think with this answer you covered a lot other questions that we've been receiving. But before we close, I just want to reflect on serological tests, because we've received a lot of interest over days on this. What have we learned so far from serological studies about immunity recovery, about antibodies, about the reinfection? So these are the frequently asked questions on our social media, and would be good if we can explain maybe once again what we know so far.
Sure. So it is my favorite question. It's my favorite question because I am very, very passionate about these serologic studies, because we as a global community have recognized the importance of these types of studies in these emerging pathogens. And 11 years ago, 15 years ago, when we were talking about H5N1, which is an avian influenza, and it's rarely circulated and it just spills over, and we had no idea the extent of this infection. And there were all these studies that were being done, and they were done differently. There was different methods used, there were different tests used, there were different populations used, and to be able to compare a study and a study, it was like comparing apples and oranges, and we just couldn't do it. And so this group came together, CONCISE, a consortium, it's not a concise acronym, the Consortium for the Standardization of Influenza Seroepidemiology. I know, I apologize, but it's called CONCISE, and it had an EPI working group and a laboratory working group. And the EPI group, we had hundreds of scientists all over the world that were developing protocols, study protocols, templates to say, if you're going to do this type of study, please follow this methodology.